Yes, next. Yes, this is about the Icon Cancer Center in Singapore, but also in Australia and in New Zealand. Next. Icon offers services across the radiation oncology, medical oncology, hematology, chemotherapy, and pharmacy services, but just now also the surgical oncology. Icon Cancer Center operates a fleet of 7 outpatient specialized oncology clinics in Singapore with 13 experienced specialists in their team. And just now, Icon introducing surgical oncology services at Mount Alvernia Medical Center. Next. Should you like to reach out to them, you may visit their website at iconcancercenter.sg. Thank you. Without further ado, let's start off with our first speaker, and I start by reading Dr. Ting Wen Chang curriculum vitae. Dr. Ting Wen Chang, his hematology training during his fellowship at the Wells National School in Cardiff, UK, and the Fred Hutchinson Cancer Research Center, Seattle, USA. Dr. Ting was awarded the Federal Scholarship to study medicine at the University of Malaya and the Asian Fellowship in Internal Medicine at the National University of Singapore. He has been recognized for his line of service volunteering at the Inner City Community Center, as well as 20 years service to the Blood Service Group. Dr. Ting also contributed to the development of Singapore's bone marrow transplantation program and was a member of the team who successfully performed the first bone marrow transplant in Singapore in 1985. He is also the board examiner for hematology exam. His subspecialty interest is bleeding and thrombotic disorders and chronic myeloproliferative lymphoproliferative disorders. Without wasting any time, let's listen to the presentation right away. Please, Dr. Ting, time is yours.
I thank you, Dr. Hannah, for the kind indication. Can you all see the PowerPoint slides on your screen?
Yes,
okay.
We can.
Thank you again for inviting me to talk to every one of you, and greetings from Singapore. And I would like to share with you this morning's topic, which is understanding blood cancer, diagnosis, and treatment. This is the outline of my talk, a brief overview, followed by diagnosis, treatment, and a short summary. First of all, blood cancers is divided into 3 main groups: leukemia, lymphoma, and myeloma. Most of these cancers originate in the bone marrow, and they are derived from multipotent stem cells. The stem cells will mature into myeloid precursors and lymphoid precursors. From the myeloid precursors, you will eventually derive platelets, red blood cell, and the different types of white blood cells. From the lymphoid precursors, you have the lymphocytes, the T and B lymphocytes, and the NK T cell lymphocytes. And the plasma cell is derived from the B lymphocytes. So in leukemia, affects the precursor or the early bone marrow cells, usually the myeloid cells, and also the early lymphoid cells. Lymphoma affects the lymphatic system, the lymphocytic cells, and multiple myeloma affect the plasma cells. The effects of blood cancer are many. The normal blood production is reduced. the blood cancer cells enter the bloodstream and spread throughout the body. It reduces the ability to fight infection when the white blood cells are reduced, and when the platelets are low, it can cause bleeding. This is a very broad outline of the classification of leukemia. It is based on the type of white blood cells affected, whether it is myeloid cells or lymphoid cells. It also depends on the onset and of the tempo of the disease, whether it is fast growing, in that case you call it acute, or slow growing when it is a chronic leukemia. So for example, you will have acute myeloid leukemia, acute lymphoblastic leukemia, chronic lymphocytic leukemia, and chronic myeloid leukemia. However, the classification is much more complicated according to the WHO classification of leukemia in 2016. Just to show you an example, for acute myeloid leukemia, it is classified according to the cytogenetic changes in the leukemia cell, and also or whether it is related to myelodysplasia or therapy related. Similarly, for lymphoma is divided into two main groups: non-Hodgkin lymphoma and Hodgkin's lymphoma. They all affect the lymphatic system, which is very widespread in our system, which flows next to the circulatory system. And when the lymph nodes is affected, it can be enlarged. And when we examine our patient, we may be able to find enlarged lymph nodes in the inguinal region, in the axilla, and also in the neck. Sometimes you can also assess the lymph nodes from the tonsils. Do remember that the lymphatic system not only affects the lymphatic system, but also affects the spleen, the thymus gland, and the bone marrow, and also the tonsil, which I mentioned just now. If you were to biopsy a lymphoma lymph node, you can see the lymphoma cells. For Hodgkin's lymphoma, the classical description is a Reed-Sternberg cell, which is a binucleate, a large cell. And this is diagnostic of Hodgkin's when you see this Reed-Sternberg cell. Again, the classification of lymphoma malignancies is very complicated. And just an example, I will show you for Hodgkin's lymphoma, you have a nodular lymphocyte predominant Hodgkin's, and also the classical Hodgkin's lymphoma, which the four categories as shown on the slide. Plasma cell disorders involve the plasma cells. These are typical plasma cells, which are large oval cells. The cytoplasm is blue or cytoplasmic. The nucleus is usually eccentric, that means it is to one side of the cell, and there is a clear zone around the plasma cell called a perinuclear halo. And these are typical plasma cells. Multiple myeloma is a cancer of the plasma cells. Sometimes it is preceded by what we call monoclonal gammopathy of undetermined significance. When the plasma cells affect only one organ system, it is called a solitary plasmacytoma. And there are other conditions which involve plasma cells, namely amyloidosis, Waldenstrom macroglobulinemia, and the so-called POEMS syndrome, where the endocrine system and the neurological system is affected. Now, not all blood cancers have known causes, but we know that there are many risk factors. For example, acute myeloid leukemia is preceded by myelodysplastic syndrome and myeloproliferative neoplasm. The other risk factors are exposure to radiation, chemicals such as benzene, prior chemotherapy or radiotherapy. There's a genetic predisposition. You know that in Down syndrome, they are likely to develop leukemia. It is also known as smoking increases the risk of acute myeloid leukemia. The family history of leukemia is very uncommon. So do remember that most persons with any of these risk factors do not get leukemia, and most patients with leukemia have no known risk factors. Now I shall come to the diagnosis of blood cancers. This is the outline of the diagnosis. You have to do a medical history, take a medical history, do a thorough physical examination, perform first some very basic laboratory tests. A biopsy is very often necessary. And then you have, with the biopsy material, you might want to do genetic tests. and do imaging and other tests. I shall elaborate on some of these modes of diagnosis. First, from the history, it is important to determine the symptoms and the duration of the symptoms. The occupation, what does the patient do, and the medication is taking. The social history, smoking, alcohol intake, and substance abuse. Past medical and surgical history, and family history is very important. The health history of the family members, and also the number of siblings. This is important when you want to try to match a sibling for a hematopoietic stem cell transplant. The symptoms of blood cancer are many. They can have swollen lymph nodes. They can have fever and night sweats, which is can be due to infection, can also be due to the cancer itself. If the platelets or thrombocytes are low, they can have bleeding from the nose. They bleed very easily when they cut themselves, or they can have red spots or petechiae on the skin. They can have severe infection like herpes simplex around the mouth, bone pain where there's infiltration of the leukemia into the bone, and also weight loss. If you examine the patient, you can find several abnormalities. General examination, you get a patient may be pale. If the platelets are low, they can have ecchymosis or petechiae, or the lymph nodes might be enlarged. The heart, there may be signs of heart failure or abnormal heart rhythm, signs of consolidation or effusion in the lungs when there's an infection. When you examine the abdomen, the spleen might be enlarged. In this case, it's a very large spleen. And with this very large spleen, you usually see it in chronic myeloid leukemia, myelofibrosis, and sometimes in lymphomas. There might be other abdominal masses and tenderness. The musculoskeletal system might have joint swelling and bone tenderness, and the neurological abnormalities will involve cranial nerve palsies when the central nervous system is affected, and peripheral neuropathy when they develop complications due to certain chemotherapy drugs. You perform very basic laboratory tests in all cancer patients, blood cancer patients, the hematology, blood count, blood film, coagulation profile, and blood grouping, the basic biochemistry, liver and kidney, electrolytes, calcium and uric acid, viral screen, hepatitis B and C, HIV, urinalysis, ECG. Lumbar puncture might be necessary if you suspect central nervous system involvement or meningitis. There are also special tests that you perform for certain selected conditions. For example, in multiple myeloma, you would want to do the immunological test for immunoglobulin IgG, IgA, and IgM, and also the kappa and lambda light chain, electrophoresis, immunofixation. LDH and beta-2 microglobulin is used for staging the myeloma. Similarly, for lymphoma, you can do the LDH, and the Epstein-Barr virus serology is done because some lymphomas are associated with the ET virus. And then you will do a bone marrow. You either do you will do a biopsy either from the marrow or from the lymph nodes. And from the marrow, you do an aspirate and a trephine, and with the Giemsa stain, histology, flow cytometry, and genetic studies. I shall elaborate a little bit on this. On the lymph nodes, you can do the histology as shown here with the lymphoma cell, or what we call immunostaining, where the cells are stained with antibodies to the antigens, which is tagged on the peroxidase. You can see this is positive for a lymphoma cell. There are other biopsies which may be necessary, for example, lung biopsy and liver biopsy. Now, what about the genetic tests? Genetic tests are very useful. First of all, for diagnosis. For example, in chronic myeloid leukemia, there is a translocation between chromosome 9 and 22. So you can detect it from cytogenetics. And you can also detect sites for targeted therapy and prognosis as well. I shall elaborate on some of these. Now, what sort of genetic tests do you do? There's a classical karyotyping where you look at the number of chromosomes and the structure of the chromosomes to determine whether there's any abnormalities or mutations. Some of the molecular tests you can do is called fluorescent in situ hybridization, where you take the cells with fluorescein and you can pick up the signal of the oncogene. For example, this is a BCR-able gene from the chronic myeloid leukemia with a 922 translocation. We now also have next generation generation sequencing, where we look at more than 100 different types of DNA sequencing to try to identify the type of mutation the patient has. And flow cytometry is very important to diagnose the different types of leukemia. It is what we call immunophenotyping. For example, if this is a T lymphocyte or a B lymphocyte, there are numerous antigens on the surface of the cells. And if you were to tag these antigens with an antibody, you pass it through a tube where a light source is usually a laser. And this one will measure the scatter of the cells. And from the different patterns, you can tell whether it's acute myeloid leukemia, B-cell ALL, or T-cell acute lymphoblastic leukemia. So immunophenotyping is very important for diagnosis of leukemias. Sometimes you can also collect the cells for further studies. Now I shall now use 4 examples to illustrate the application of the diagnostic test which I mentioned just now: acute promyelocytic leukemia, and also 3 other conditions involving the patients that I recently looked after. First of all, acute promyelocytic leukemia is a very interesting leukemia. It affects about only 5 to 8% of acute myeloid leukemia. It is characterized by the appearance of numerous promyelocytes in the blood and the bone marrow. The promyelocytes are a very typical appearance, very prominent nucleoli, and also what we call IO rods in the cytoplasm. And the promyelocytes are along the line of differentiation of the myeloid cells, finally in the forming of the mature neutrophils. So in acute promyelocytic leukemia, there is an abnormal production of the promyelocytes. It is associated with severe bleeding disorders due to disseminated intravascular coagulation. Now, what causes acute promyelocytic leukemia? It is caused by a translocation of the 1517 chromosome. You remember just now I told you chronic myeloid leukemia is 922. In this condition, it is 1517 translocation. This results in the formation of an oncogene called PML-RARA. And this PML-RARA acts on the promyelocytes, which prevents maturation of the promyelocytes to the more mature cells. And this is detectable by fluorescent in situ hybridization. This condition responds very well to differentiating agents such as all-trans-retinoic acid and arsenic trioxide, which allows maturation of these cells into the mature cells. Now, this is a patient, a 41-year-old lady, which referred to me for a very high white cell count. She presented as pneumonia. As you can see, her white cell count is very high, 140. Hemoglobin is low, 9.8, and the platelet is only 29. And what is very important, there are 53% blast cells in the peripheral blood. A bone marrow is done. It shows that there are 70% blast cells in the bone marrow. Again, typical appearance of a myeloblast. But we need flow cytometry to confirm the patient has got AML. And these are the typical immunophenotypic presentation of a patient with the AML. Next generation sequencing was done. We detected 7 abnormal the genes, and of which the FLT3 and RUNX1 were detected, and these are associated with the poor prognosis. The next patient is a 72-year-old man presenting with weakness. He has no fever, no bleeding, no bone pain. Very interestingly, he works as a physicist in the radiotherapy department. Now, he was feeling weak and tired because his hemoglobin was only 5.6. He's got some evidence of renal impairment, creatinine 137, the estimated GFR of 45. The protein is very high, 134, comprising mainly of globulins. The calcium in this case is low. Usually in this condition, the calcium is high. The uric acid is high, the blood sugar is normal. Bone marrow was done. Again, it shows plasma cells, which I discussed to you just now. Cytogenetics showed these abnormalities, and these are not known to be associated with a poor prognosis. A PT scan shows osteolytic lesions generalized in the bones, in the manubrium, in the vertebra, and in the pelvis. If you do the immunoserology, the patient's IgG is very high, 98. The kappa light chain is also very high. So is the kappa light chain ratio. Beta-2 microglobulin is elevated. This implies a poor prognosis, and the M band is detected. And we follow up multiple myeloma patients with the M band. The serum protein electrophoresis showed that there was a monoclonal band at the gamma globulin region. The immunofixation shows monoclonal protein in the G and in the kappa light chain. And the diagnosis is, in this case, is typical of multiple myeloma. The third patient is a 55-year-old man presenting again with a very high white cell count. Yes, and in the blood film, you can see there are also early cells like myelocytes, metamyelocytes in the blood film. The myelocytes is about 20% in this patient. He has got very mild fatigue. His spleen is not palpable. Cytogenetics shows 922 translocation, and the BCR-ABL transcript was detected by PCR. The diagnosis clearly is chronic myeloid leukemia. I shall now come to imaging for blood cancers. Very often, just a simple X-ray will provide you with a very rapid and basic information. Ultrasound is useful for evaluation of the liver and spleen involvement. Sometimes venous thrombosis is associated with blood cancers, so you can do a Doppler ultrasound of the lower limbs. And in patients treated with the anthracyclines, a 2D echo is useful. CT scan provides, of course, very detailed information about most organs, but PET scan is even more useful because it detects the metabolic activity of the tumor. In this case, you can see they are lighted up with a bright orange or yellow color. So it's also useful for staging of lymphoma. So after treatment of lymphoma, I will repeat the PET scan to see whether the lymph nodes have been reduced. MRI is useful for musculoskeletal, central nervous system, and hepatic lesions. Now I shall come to the treatment. This is the treatment strategy. First of all, you have to confirm the diagnosis, and also you have to determine the prognosis by what we call risk stratification. You evaluate the patient for fitness, and then you decide whether the patient requires treatment. Now, having with these four information, you have very importantly discuss with the patient and the relatives about what has been found so far. Then you will select the treatment. If there are complications, you manage the complications. You document whether the patient has responded to response, and you monitor for relapse. So for prognosis or risk stratification, there are many types. So for example, for acute myeloid leukemia, you use the European network risk stratification. Chronic myeloid leukemia, something called Sokal score. Oh, by the way, those of you who are not familiar with this Kaplan-Meier plot, it is to look for survival. On the horizontal axis, it is the time in can be months or years. In the vertical axis, it is the percentage or the proportion of the patients. So if the patient has got a very good survival, the line is at the top. Okay, so for example, chronic myeloid leukemia with a high Sokal score, the prognosis is very good. Similarly, for B-cell lymphoma, you have the international prognostic score, and multiple myeloma, the revised international scoring system. Next is an example of for acute myeloid leukemia. The prognosis depends on the mutation, on the cytogenetics of the patient. Whether they got a favorable cytogenetics like translocation 821, or very poor risk cytogenetics like mutation of TP53. So those with a good risk cytogenetics has got a better prognosis compared to those with very poor risk. Now, once you've decided on the treatment options, there are many options. Some patients only require observation or supportive treatment. Then you may have chemotherapy, radiotherapy, targeted treatment, immunotherapy, hematopoietic stem cell transplant, and cell therapy, the latest, which are what we call CAR T-cell therapy. I shall elaborate on some of these treatments. First of all, there are certain patients which only requires observation. Examples of these are early chronic lymphocytic leukemia, early follicular lymphoma, and early multiple myeloma. Do remember, these patients do not need treatment yet, but you have to monitor them very closely. There are also certain patients which are very old, has got multiple comorbidities like heart failure, renal failure, previous stroke, and so on. And in this case, you only get supportive treatment, and with the treatment is with transfusion and symptom control. This is once you've decided on the management, this is the overall management plan. You counsel the patient. Financial counseling is very important because the drugs now used for cancers are very expensive. Of course, they also require social and psychological support. And the patient, you have to determine the patient and the relatives' expectations. What do they expect the doctors to do for them? This is very, very important. For those who are in the reproductive age group, for the females, you want to offer them ovarian tissue preservation, and for the men, sperm preservation. You relieve the side effects of the therapy. For example, nausea, vomiting, pain control. And because their white blood cell is very low, sometimes prophylaxis against fungus, bacteria, viruses, and pneumocystis are required. When you treat the patient, there can be biochemical abnormalities in the electrolytes, in the calcium, blood sugar, and so on. And if the blood cells are very low, they might need to have red cell and platelet transfusion and granulocyte colony stimulating factors for neutropenia. First of all, chemotherapy, it works by inhibition of cell division. Now remember, chemotherapy affects both malignant cells and also normal cells. Hence, it is associated with numerous side effects. There are also problems with vascular access. After a while, you cannot find a vein to take blood or to introduce the chemotherapy drugs. In which case, you have to use a peripherally inserted central catheter, what we call a PICC line, from the cubital fossa into the right heart, and or else what we call a venous access port, which is a subcutaneous, which also with a catheter into the heart. And this will enable us to deliver our chemotherapy much efficiently. Very often, chemotherapy is used in combination with immunotherapy and corticosteroids. Some examples of chemotherapy are for AML, the classical daunorubicin and cytarabine, ALL, vincristine L-asparagine, non-Hodgkin's lymphoma. This is used to the classical CHOP chemotherapy, vincristine, cyclophosphamide, erythromycin, and Hodgkin's lymphoma using these drugs in what we call the ABVD chemotherapy. Chemotherapy is usually given by IV infusion into the peripheral vein, and when you need an infusion pump. And if the infusion time is very long, sometimes 8, even 12 hours, the patient can go back with the infusion pump attached to their with a portable device. The chemotherapy effects can be general or organ specific. The general effects are nausea, vomiting, poor appetite, weakness, hair loss, infertility, and so on. And then there are the organ specific. It's well known that anthracyclines causes cardiac complications, bleomycin pulmonary, vincristine peripheral neuropathy, cyclophosphamide hemorrhagic cystitis, and so on. Now, first of all, you have to, if the patient already has got cardiac or pulmonary involvement, you might want to avoid using these drugs, or if you have to use the drugs, you may have to reduce the dose. Next, we come to radiotherapy, which is very useful in blood cancer. For example, in Hodgkin's lymphoma, it is used in combination with chemotherapy. It is very good for pain relief, especially for bone secondaries in multiple myeloma. In compression syndrome, for example, in superior vena cava obstruction, in mediastinal lymphomas, or spinal cord compression, emergency radiotherapy is required to relieve the compression. It's also used for hematopoietic stem cell transplant as part of total body irradiation in the conditioning of the patient. We now come to the final part of therapy, which is targeted therapy. There are two main types, small molecule inhibitors and immunotherapy. The immunotherapy may consist of an anti-tumor antibody, or there might be a conjugate or a toxic drug attached to the antibody. The others are like immunomodulatory drugs, bispecific antibodies, checkpoint inhibitors, and CAR T-cell therapy. And the last three categories are becoming more popular in use. Now, what is immunotherapy? It is targeted therapy. It is targeted therapy on certain pathways within the cell. If this is the cancer cell, this is the cell membrane, and this is the nucleus. And there are receptors on the cell membrane. So if the receptors are activated, by antigens, then it triggers off a reaction along this signal transduction pathway in the cytoplasm and finally into the nucleus. So as you can see, there are so many receptors and so many proteins within the cytoplasm and nucleus which are targets for your therapy. And these are some of the sites where we commonly use targeted therapy in blood cancers. And these are, for example, in chronic myeloid leukemia, these are the tyrosine kinase inhibitors, imatinib, nilotinib, and dasatinib. And in myeloproliferative neoplasm, ruxolitinib. Venetoclax and ibrutinib are also becoming useful now. So this is just examples. There are several drugs which you can use for targeted therapy using small molecules. Now, next we come to immunotherapy. Immunotherapy is, for example, in a B-cell lymphoma, where there are CD20 antigens on the surface of the lymphoma cells. You have antibody to CD20. In this case, it is rituximab. Now, rituximab will act on the CD20, and this results in apoptosis or cell death of the lymphoma cell. So rituximab is anti-CD20. In Hodgkin's, it is anti-CD30, but in this case, you need to have a drug. You need to have a conjugate called vedotin, which is toxic to the Hodgkin cell. In multiple myeloma, anti-CD33, in ALL, anti-CD22, and also in AML, anti-CD33. There are a lot of other monoclonal antibodies. These are just a few examples. Finally, we come to hematopoietic stem cell transplant. There are two types: autologous transplant, where you use the patient's own stem cells, or allogenic transplants, where you use stem cells from a compatible donor, which may be related or unrelated to the patient. The currently uses for transplant in blood cancers are consolidation therapy in multiple myeloma, where you use an autologous transplant, and relapse lymphoma is also autologous transplant. For some conditions like high-risk AML, acute myeloid leukemia, transplants are necessary. So how is it done? First of all, the patient, we have to collect the stem cells from the patient. It's usually from the blood. We have to mobilize the stem cells by giving them cyclophosphamide and growth factors like colony stimulating growth factors. In this case, the white blood cell will go up. The stem cells will circulate in the patient's circulatory system. And then you collect the stem cells by a method called apheresis. However, this is for autologous transplant. This is for allogenic transplant, where you use a donor. Of course, you don't give cyclophosphamide, you only give the growth factor. At the meantime, the patient undergoes what we call conditioning with very intensive myeloablative chemotherapy and radiotherapy. You will reduce the white cell, the bone marrow cells practically to zero in order to remove the cancer cell and create space for the transplanted cells to populate the marrow. The stem cells are transplanted exactly like a blood transfusion. It takes more than 3 weeks or more for the stem cells to mature into mature cells. At this time, they require support with antibiotics, antivirals, etc. Now, there are several problems, and the whole process takes sometimes as long as 4 to 6 months for the patient to recover completely. But there are several problems with stem cell transplant, like the availability of donors. Nowadays, our families are very small. Graft-versus-host disease, infection, sinusoidal obstruction syndrome, like in causing liver problems, and long-term effects like secondary cancers, depression, lung toxicity, and so on. Okay, so now we have treated the patient. You have to evaluate the response to treatment. Is the patient under control? For acute leukemia, the blood counts must become normal. Typically, they must have been less than 5% blood cells in the marrow. And now we got this new technique called detection of minimal residual disease, where you detect up to 10 to the -5 tumor cells in the circulation. You can use flow cytometry or PCR to determine the MRD. For lymphoma, which I mentioned just now, you repeat the PET scan to see whether the lymph nodes has been resolved. For multiple myeloma, you will measure the reduction in the monoclonal proteins and also MRD as in acute leukemia. Now, back to the 3 patients which I look after. The first patient is the lady with the AML. She has a very unfavorable mutation called a FLT3 mutation. As such, she was treated with a classical cytarabine and idarubicin. On top of that, she had midostaurin, which is a FLT3 inhibitor. Because it is a very poor prognosis, she was also given an allogeneic transplant from her sibling. And at 16 months follow-up, she is still in complete remission. The second patient is the 70-year-old man who was a physicist in the radiotherapy department with multiple myeloma. He had what we call intermediate risk multiple myeloma, treated with this triplet of bortezomib, lenalidomide, and dexamethasone. Follow-up at 8 months, it is still in complete remission. Finally, is the third patient with CML with the so-called score of intermediate risk. He was treated with a tyrosine kinase inhibitor, nilotinib, and in 6 months, he has already achieved major molecular remission. Now, there are many success stories in blood cancers, and that will, for example, for pediatric acute lymphoblastic leukemia, with the use of dose intensification therapy and sometimes a transplant, the prognosis has improved. In the 1960s, it was only about 10%. Now it is in excess of 90% for pediatric ALL. Similarly, for chronic myeloid leukemia, in the beginning, just with hydroxyurea and busulfan, the survival is only about 10%. And the chronic myeloid leukemia will turn into acute myeloid leukemia. Subsequently, with interferon and bone marrow transplant, the prognosis has improved a little bit. But in the 1980s, with the introduction of imatinib, the response rate is now 80% or more. The other examples of successful stories are acute promyelocytic leukemia, which I mentioned just now, and also something called hairy cell leukemia, where the survival is more than 90%. But not all leukemias blood cancers are treatable so well. There are also those with very poor prognosis. These are those with elderly age, multiple comorbidities, high tumor load, unfavorable cytogenetics, and central nervous system involvement. For example, in adult ALL, the younger patients have a better survival than the older patients. In a B-cell lymphoma, there's something called a MYC mutation and a BCL2 mutation. Those with this mutation has got a very poor prognosis compared with those without this mutation. And finally, unfavorable cytogenetics, which I mentioned just now. Those with unfavorable cytogenetics, survival is only 20%, whereas those with favorable, it is in excess of 80%. Again, it is age-related. Those who are older has got a poorer prognosis. Now, ladies and gentlemen, I thank you for your attention. I will just summarize with one slide on the advances we have made in the management of blood cancers. In diagnosis, we have flow cytometry, immunochemistry, and fluorescent in situ hybridization. For prognosis, we have CT scan, which is a next generation sequencing, international prognostic scores, and detection of minimal residual disease. For treatment, we have targeted therapy and the various types of cell therapy. And with this, I thank you for your attention, and I'll be happy to answer any questions that you all may have.
Okay, thank you, Dr. Ting. Thank you very much for the fruitful presentations, which has broadened our insights about hematology cancer. Now it's time for a discussion session. Please welcome for those who want to ask a question to Dr. Ting. Please provide the question to the chat. Please mention your name and institution. I see there's one or two questions from Dr. Diana. How successful blood cancer therapy is and what factors support healing?
The success of the chemotherapy depends on the general condition of the patient, and also on the sometimes cytogenetics of the patient. So those young patients with a very favorable cytogenetics and early stage disease, the response rate is very good. For example, early Hodgkin's the lymphoma, it can be in excess of 90%. Whereas those with a very elderly patients, say somebody in the 80s with a heart condition, with a very aggressive lymphoma, the survival is very poor, down to 10 or 20%.
Yes. Hello. Yes, thank you, Dr. Ting. How about Dr. Diana? Is Dr. Ting already answers your question?
Yes, thank you, Dr. Ting.
Yes, Dr. Diana.
Yeah, the next question from Dr. Joseph Tarong. Which one from the blood cancers the most responsive for the immunotherapy? And for patients that older than 65, why we usually don't recommend for stem cell transplantation? Thank you.
For immunotherapy, I think the very successful ones will be diffuse large B-cell lymphoma, where we use rituximab in combination with the chemotherapy, what we call R-CHOP, and the response rate for diffuse large B-cell lymphoma with R-CHOP, it is very good. It is somewhere in the region of about 60 to 80%. And for stem cell transplant, nowadays, age is not the only important determinant of whether the patient is fit for transplant. There are patients even above 70 years old, where their general condition is favorable, they can also be subjected to transplant. And of course, autologous transplant has got less morbidity and mortality compared with allogenic stem cell transplant.
Okay, thank you for the answers. Okay, I think, is there any question from the participants? If no, I have two questions to Dr. Ting. First, in Singapore, is it routine to do the immunophenotyping with flow cytometry or with immunofluorescence hybridizations for patients with suspected hematological disorder? And the second question, what factors determine the choice of therapy? Is the patient will use the targeted therapy, chemotherapy, or immunotherapy? What factors determine the choice of therapy?
Okay, thank you for the question. The first question is for leukemias. We usually use flow cytometry to the immunophenotype of leukemia, whether it's AML, different types of AML, and also for acute lymphoblastic leukemia, whether it is T-ALL or B-ALL. Fluorescent in situ hybridization, it takes a bit longer to do. Flow cytometry is only one working day we get the result. For the fish, it takes about 2 or 3 days, and it's also less useful because you can test for less antigens with the fish. Whereas for flow cytometry, there are many antigens that you can pick up. As to the second question, it is a good question as to which modality of treatment do we choose, whether it's chemotherapy or targeted therapy. The tendency now is to move away from chemotherapy. In other words, we call that chemotherapy-free treatment. So, but unfortunately, we still need to have chemotherapy in combination with immunotherapy to treat some of these conditions. For example, in diffuse large B-cell lymphoma, we have to use rituximab in combination with the chemotherapy. But there are now several immunotherapy monoclonal antibodies which are very useful, especially in the relapse setting, where we can use with a very good response. For example, in Hodgkin's lymphoma and also in multiple myeloma, there are monoclonal antibodies and targeted therapies now which are useful.
Okay, thank you for the answers. Thank you. There another question from Mr. Michael from Bandung. How does ICON treat patients with cancer terminal illness? What are the methods of palliative care being used there? It's about the palliative care.
Okay, the question is about palliative care, is it?
Yeah.
Okay.
Yeah.
Again, palliative care is very important. I mentioned in my slide just now, we have to find out from the patient and the relative, what is the expectation of, what is their expectation? Do they want us to treat as intensively as possible to try and attempt a cure, or they only want us to give a palliative treatment? So in terms of palliative treatment, you will be mainly on pain control, symptom control, and also psychological support.
Okay, and ICON also have a service for the palliative care in ICON?
At the moment, we do not have a palliative care physician, but there will be a useful member to introduce into our team, because palliative care is very important. But most of the oncologists in the ICON group are aware of palliative care, and at certain stage in time, we will offer the option of palliative care instead of aggressive therapy for the patient.
Okay, thank you. Yes, the answer for Mr. Michael. And the next question from Dr. Puspa from Jakarta. What is the role of corticosteroids in leukemia therapy? In what condition corticosteroid is used as combination with chemotherapy? Do specific examination is needed before starting targeted immunotherapy? And when to start targeted immunotherapy and how long? Please, Dr. Ting.
Okay, corticosteroids is usually used only in acute lymphoblastic leukemia and in multiple myeloma. It is not used for acute myeloid leukemia. And also in B-cell lymphoma, corticosteroids are used as well. As to how we decide on which immunotherapy or targeted therapy to use, we have to depend very much on the cytogenetics or the immunophenotyping of the tumor cell. So with the next generation sequencing and also with the fluorescent in situ hybridization, we can identify the targets. For example, we find a FLT3 mutation, then we use a FLT3 inhibitor to treat the condition. If the patient, for example, in acute myeloid leukemia has something called an IDH mutation, then there are certain drugs which are directed against those drugs. I hope that answers your question.
Yeah, thank you. Okay, for the next question from Manda Rodrigo, his students from our institution. What is the gold standard examination for blood cancer? What is the percentage success in immunotherapy and what are the obstacles to the therapy? Thank you.
The gold standard for leukemia, it is still a bone marrow biopsy and flow cytometry. We have to depend on that to, first of all, to confirm whether the patient has a leukemia, and the flow cytometry to tell us which type of leukemia the patient has. So all leukemia patients, we require this in this test. The second question is about the, I'm sorry, it's about
what is the percentage success in immunotherapy and what are the obstacles to the therapy?
Okay, yeah, okay. The success rate of immunotherapy, of course, depends on the condition the patient is having. At the moment, immunotherapy is used mainly in those patients who have relapsed. So the prognosis is not very good, but there are now attempts to use immunotherapy upfront as a first line of treatment in combination with chemotherapy, and the success rate will be much better. The obstacles of immunotherapy, I think it is, the main obstacle will be the financial cost. Immunotherapy and targeted therapy are extremely expensive. Sometimes the treatment may go on for 6 months or even longer than 6 months. So the cost factor is very important. And sometimes immunotherapy can cause a certain adverse reaction like a fever and chills and rigors, drop in blood pressure, and also involvement of the immune system causing infections.
Yes, thank you for the information about immunotherapy. There's also the side effect. Then the next question from Dr. Diana, what are the requirements of stem cells transplantation for blood cancer?
Okay, first of all, stem cell transplant for blood cancers, there are two types. The autologous transplant, where we use that for multiple myeloma, for those who are transplant eligible, and also for B-cell lymphoma when the patient has a relapse. For allogenic transplant, there is what we call a comorbidity index, where we look at the fitness of the patient for transplant. So this depends on the renal function, kidney function, cardiac function, the age of the patient, and so on. The other criteria is in allogenic transplant is finding a suitable donor. The most ideal will be a match, HLA match related sibling, all right, from a brother or a sister. But unfortunately nowadays our families are very small. We only have sometimes one or two siblings or none at all. So in which case we have to either use a cord blood transplant, or we use an unrelated transplant from the computer registry.
Yes, okay, thank you for the answers. And the next question from Dr. Herdi from Bandung. With the current condition about the COVID-19 pandemic, how about the incidence of COVID-19 in leukemia patients? How is the handling done in patients with COVID-19? In patients with COVID-19 but also have the leukemia comorbid?
Fortunately, in Singapore, most of our patients, I don't think any of the COVID-19 patients have got leukemia. They mainly affect the foreign workers and the young patients. And there are so far 30 deaths in Singapore from COVID-19. And these are mainly from cardiovascular complications. And as far as I know, none of these patients have got blood cancers.
Okay, I think the prevalence of COVID-19 in Singapore is not so high as in Indonesia. Okay, then still two questions. Is it okay, Dr. Ting?
Yes, of course.
Yeah. From Dr. Tejo from Faculty of Medicine, UKDW. I think it's from Yogyakarta. What is the role of growth factors to treat MPD-MDS? What is the role of growth factor to treat MPD-MDS?
Okay, so there are two growth factors which we use for, you're talking about MDS, isn't it? And the myeloproliferative neoplasm. Yes. Okay, to treat the low hemoglobin, we use erythropoietin. And for those who are neutropenic, we use GCSF, either Neupogen or Nivastim. Now, as to use of thrombopoietin, like Eltrombopac in myelodysplastic syndrome, its use is still controversial, is still under studies. So for those with low platelets, we tend not to use Eltrombopac to treat patients with the thrombocytopenia for concerns that it might turn into acute leukemia.
Yeah. Okay, Sitina. Now the next question from Professor Susi Cahyani. Which ones is the least side effects? I mean, she wants to know the comparison, the side effects between immunotherapy and targeted therapy. About this.
I think immunotherapy, we have learned how to handle the situation. Rituximab used to treat diffuse B-cell lymphomas has been with us, I think, for almost, I think, close to 10 years already. So we have learned how to handle that one. It is usually just infusional reaction when the antibody is being introduced to the patient. They develop the low blood pressure and so on, and later on they may be their own immunoglobulin levels are low, so we have to monitor them. So immunotherapy, I think it's not difficult to manage because we have the experience. Targeted therapy is a different story altogether because they are new drugs. I think probably less than 5 years old, less than 5 years in Singapore. So for example, ibrutinib used to treat chronic lymphocytic leukemia. They have cardiac complications, and also venetoclax used to treat myelodysplastic syndrome. They have a tumor lysis syndrome. However, the other targeted therapy, which is found to be very safe and we have already used for a long time, are the tyrosine kinase inhibitors like imatinib and nilotinib for treatment of chronic myeloid leukemia. That one has been with us for more than 10 years, and we are very familiar with the side effects, and they are usually very easily managed.
Yeah, thank you. But I think for targeted therapy have a least side effect when we compare with chemotherapy or radiotherapy.
Certainly,
yes.
Certainly. That's why we are going towards targeted therapy now, and even more advanced now, which is CAR T-cell therapy.
Yeah, thank you. The next question, I think will be the last question. What could be the obstacles for treating children with leukemia with immunotherapy? What should we prepare before the therapy? This is from Dr. Han from Bandung.
I have to apologize. I'm not a pediatric hematologist. So I'm not aware of any obstacles in treatment. The success rate with childhood acute lymphoblastic leukemia is excellent. And there are also now immunotherapy available for pediatric ALL with very good results. But I have to apologize. I do not look after pediatric patients.
Okay, thank you. Maybe Dr. Han can also email to ICAN and ask about these questions.
Yes, we have a pediatric oncologist in our group.
Yeah, okay, thank you. I think, is there any question? One more question, Dr. Ting.
All right.
This is from Ellie from Batu, East Java. In patients who receive imatinib for a long time, what should we monitor about drug side effect?
Usually, imatinib even after 6 months to 1 year treatment, there are no more. The side effects are very, very few or none at all. The more important question is, can we stop? When can we stop imatinib? And now we are able to do the molecular estimation, and those which has got a very, very deep response, we can attempt to stop the imatinib. And this has been attempted in a proportion of patients.
Yes, okay, thank you. I think time flies, so we will finish this session. Thank you very much to Dr. Ting. I'm sure we have gained tremendous knowledge about hematology cancer. And before entering the next session, the committee wants to give a certificate of appreciation to Dr. Ting. Please, Dr. Jefferson, can you share the certificate, and we will send the certificate to Ms. Joyce. Thank you, Dr. Ting.
Thank you, Dr. Hannah. Thank you, yes. Dr. Jefferson. Okay,
thank you.
Bye.
Thank you, Dr.
Bye.
In the next.
Thank you, Dr. Ting. We're looking forward for our next follow-up.
Yes, thank you. Okay. Now we will join the next session. The second session will be from Ibu Dr. Wahyu Widowati with the topic potential plant-derived natural products and stem cells for leukemia therapy. This is the CV of Dr. Wahyu Widowati, MSc. Dr. Wahyu Widowati, MSc, place and date of birth from Malang, 17 April 1960. So today is her birthday. Happy birthday, Dr. Wahyu.
Thank you very much, Dr. Hannah.
And the academic qualification from Brawijaya University, Malang, for the bachelor degree, for the master degree from Gajah Mada University, Yogyakarta, and the doctorate degree from University of Pajajaran and Brawijaya University. There are so many research and publications from Dr. Wahyu Widowati. When I read the publication, maybe I need to read for 30 minutes or more. So I think all of us already know about Dr. Wahyu Widowati, his focus in research. Without wasting any time, we will start with the second session. Please, time is yours.
Okay, thank you. Okay, thank you very much, Dr. Hannah. Thank you very much for all participants. Good morning, ladies and gentlemen. Thank you very much to Universitas Kristen Maranatha who gave me the opportunity to share my research, little experience about blood cancer with entitled Potential Plants Derived Natural Products and Stem Cell for Leukemia Therapy. Cancer, I think that is my presentation, maybe a part of my slides, same with Dr. Ting. And then the start of my presentations, cancer, which the first, we know that before the cancer, we know that benign tumor is not cancer, is not dangerous, which a tumor is abnormal lumps or growth of cells, which cells in tumor are normal. It calls benign. So benign will not invade nearby tissue or spread to other areas. So benign is normal. And cancer are abnormal cells, can grow speeds and then can invade, spread, and have a feature immortality. And many signs and symptoms of general tumors, such as lumps and abnormal bleedings, prolonged cuts, unexplained weight loss, and bowel change, bladder change, fatigue, breathing, and many symptoms beside that. And over 200 types of cancer in our bodies, and maybe only hair and nail cannot attacked by cancer. All parts, organs, tissue of our body can be attacked by a cancer. And then loss of normal growth control, cancer of loss of normal growth control. Normal cell division, we know that F cell damage, maybe by many factors, can repair, and then cell can suicide or apoptosis. But cancer cell division in cancer cell, we know that we have many states mutation. First mutation, second mutation, third mutation, fourth mutation, and uncontrolled growth. And this cancer will be dangerous and damage all parts of our body. And then what's the cancer cell characteristics? many cells that continue to grow and divide, and then normal cell only grow normally, proliferate normally, but cancer cells grow abnormal and proliferation abnormal. And then variation in size and shapes. Normal cell have a normal size and shape, but cancer cell have abnormal size and abnormal shapes. And then nucleus of normal cells have a normal nucleus, but cancer cell have a larger and darker than normal. And then cancer cells, abnormal number of chromosomes arranged in disorganized fashion. And then a cluster cell without a boundary. Cancer have a larger and variability size, and then many dividings and disorganized, variation in size, variation in shapes, and loss of normal of control. Tumor progression, that's all cells have stem cells. In normal, stem cell can divide and proliferate, but still in normal. And stem cell right now as a promising therapy. And stem cell divide multipotent progenitor and committed progenitor and become mature cells. And in cancer cell have a high proliferation with stem cells, a mutation in stem cell, and multipotent progenitors, and then become dividing, and proliferating, and high proliferating. High proliferation and low cell death, and high immune evasion, and then high cell renewal. This is a character of a tumor progression. And then the progression of cancer at the first, that pro-cancer displays dysplasia and carcinoma in situ in the localized, and then become early locally advanced, and then late locally advanced, and metastasis to many organ, to many tissue, and all can disparate, can invade to many organs. And then this is the how to cells, cancer cell metastasis, and then divide to many cells. Normal epitheliums, and then we know that cells, cancer cell can spread and follow the blood, lymphoblood vessel, and then cancer cell can metastasis and follow the blood. And then this is the metastasis, and then tumor, and then angiogenesis, and then invasion to many organs. And then cancer epidemiology, we know that 2018, 18 million new cancer cases in the global, cancer mortality 9.6 million cancer death. We know that's maybe 50% from new cancer cases get mortality. We know that America 21 new cases, and then America mortality 14.4, and then we know that Asia 45.8 new cases, but Asia get mortality 57.3. I think that is become focus. We must focus that a mortality higher than new cases. This is we know that the therapy is still maybe less success. That more than mortality, more than new cases, incidents, and we know that America and then Europe's lower than new cases. And then cancer epidemiology, the incidence, the lungs cancer, 11.6, and then breast cancer, 11.9, number 3 colorectal, 10.2, and then prostate, 7.1, and then mortality, different with incidence, the lungs still number 1, 18.4. This is more than incidence. There's lungs incident 11.6 and mortality 18.5, and the number 2 colorectals, and then number 3 stomachs, and then breast cancer take place number 6, 6.6%. I think this is incident number 1, but mortality breast cancer takes place number 5. This is better for therapy, more success for breast cancer cell. And then cancer epidemiology, especially for blood cancer in USA, I don't find data from Indonesia. This is from USA. US, that every 3 minutes, 1 person diagnosed blood cancer, 178.520 people diagnosed leukemia, lymphoma, or myeloma, and new cases, leukemia, lymphoma, myeloma are expected 9.9%. We know that lung cancer 14%, and then blood cancer 11%, breast cancer 13%. Plus, blood cancer epidemiology, that estimated global incidence, an estimated 1.24 million blood cancer cases occur annually worldwide, accounting for approximately 6% of all cancer cases. That is the incident 6% from cancer cases, and then lymphoma of 615.993, and then leukemia 454.341. Worldwide, approximately 720,000 people die from blood cancer every year, accounting for more than 7% of cancer deaths. Leukemia causes 3,500 deaths from 3 million. This is blood cancer is important. Very take place number 2, yeah, lymphoma most common form of blood cancer. 5.3 of all cancer, lymphoma 5.3 of all cancer. And then incident mortality leukemia. Every 3 minutes, 1 person diagnosed blood cancer, and new cases leukemia 9.9%, estimated 1,806 and 590 new cancer. And then in USA, every 9 minutes, someone dies from blood cancer, 156 people daily. Leukemia, lymphoma, myeloma expected to cause the deaths estimated 56.840 40 people, and then 9.4% deaths from cancer. Blood cancer. Blood cancer is a malignancies. Many types of blood cancer, which cancer from bone marrow and blood, and then lymphatic system. Many types of blood cancer, lymph nodes and lymphatic vessel, and then tonsil, thymus, spleens. Bone marrow aspirate a smear from person with a precursor B cell. The large purple cells are lymphoblasts. And then specialty, this is lymphatology, oncology, and symptoms of blood cancer, generally feeling tired, a pale color, fever, easy breathing or bruising, bone pain, and large lymph nodes. And complications, infection, tumor-lysis syndrome, and usually onset to until 5 years old. Types B cell ALL and then T cell ALL. Causes are usually unknown, and a risk factor identical twin with ALL. And then diagnose method, blood test, bone marrow examination, and then differential diagnose infectious mononucleosis, acute myeloid leukemia, lymphoblastic, lymphoma, aplastic anemia. Treatment, chemotherapy, stem cell transplantation, radiation therapy, targeted therapy. And then who can attacked by blood cancer? More than children, more than 90%, 5 years survival rate. Causes of blood cancer. Different leukemias, different causes of DNA. This is a cause of blood cancer, the DNA mutation maybe by radiation of carcinogenic substance, and activating oncogenes, many types of oncogenes like BCL2, yeah. This is oncogenes, and then deactivating tumor suppressor genes, and then disrupting cell death regulation, differentiation, and then diffusion, and then ionizing radiation, human T lymphotropic virus, and many chemical who works in the chemical industrial have more suspected blood cancer, especially benzene and formaldehyde. This is substance can cause blood cancer. Genotoxic stress select of human stem cell carrying mutation in DNA response gene. We know that TP53 mutation, yeah, aging-related mutation, and then growth arrest fusion apoptosis, and then induce blood cancer. I want to
sorry, Bu Wahyu. 10 minutes left for the presentation.
Okay. Types of blood cancer: primary type blood cancer, leukemia, and then by speed disease, acute which character fast growing, rapidly dividing, and then most in pediatric, and then chronic, slower growing, mature in mature cell, haven't noticeable symptom for years, commonly adults. By cell types, myelogenous or myeloid leukemia develop from the myeloid stem cell, and lymphocytic leukemia, and then develop from the lymphoid stem cell. The major types of leukemia: acute myeloid leukemia, AML, common type of acute leukemia more than 65 years, and then acute lymphocytic leukemia, common Hispanic white, less than 20 years, and then chronic myelogenous leukemia. And then leukemia, various subtype leukemia, higher risk for developing leukemia, previous cancer treatment, radiation and chemotherapy, history of smoking or working chemical, and then genetic disorder, diagnosis and test. I think this Dr. Ting have present this similar with this presentation. Lymphoma symptoms, psychological, fatigue, loss of appetite, and then lymph nodes, and then lymphocytes, enlarged lung, shortened breath, and then liver enlargement, kidney nephrotic syndromes, and bone marrow involvement, and systemic weight loss, loss of appetite, and fever and nights, and many kinds of symptoms of lymphoma. And then leukemia, and then similar but specific, different with lymphoma. And then acute myeloma, myeloid leukemia raised by genetic abnormality, many kind genetic influence the AML. This is RANS, X1, and then a mutation NPM1 and TPPA, and then intermediates NPM1, FLT3, and then MLLT, and then adverse DEX, NAPS, and then PCR ABL, and then gene mutation in MLL, many kinds of theory, and then many kinds of genes are involved in mutation of AML. This is potential contributing in PI3K, AKT activation, AML, FL3, and then mTORC2, PTEN, SIP, and many kinds. And then this is my research with my friends for blood cancer, especially leukemia, acute myeloblastic leukemia. This is that's our substance influence to FLT3 and then AKT, especially to cell proliferation, to decrease cell proliferation, and then to apoptosis, caspase-9, caspase-3, and then to cell cycle. I will present our data. This is PI3K, AKT, mTOR signaling pathway. This is that many protein affect the signaling pathway. We know that's mTOR C1 and mTOR C2. And then TP53 pathway in acute lymphoblastic, TP40 is influence to apoptosis. And then leukemia treatment, chemotherapy, targeted therapy, radiation therapy, immunotherapy, bone marrow transplant, and stem cell therapy. And then therapeutic targets in PI3K, AKT, and mTOR signaling pathway, many kinds of drugs for therapy, blood cancer therapy. And then blood cancer therapy right now have been developed using natural plants, natural products, and then nanoparticle and stem cell transplantation. Tissue stem cell from hematopoietic stem cells can be differentiated to NK cell, T cell, B cell, dendritic cell, and then platelet, erythrocyte, macrophage, neutrophil, eosinophil, basophil, specialist cell, and then many blood cancer therapy using hematopoietic stem cell. And then autologous and allogenic therapy, autologous from the patients, and then allogenic from donor. And then different type of stem cell for stem cell transplantation from pluripotent stem cell, human embryonic stem cell, induced pluripotent stem cell, and then adult stem cell from bone marrow stem cell, peripheral blood stem cell. This is hematopoiesis, and then from umbilical cord blood, and then from non-hematopoietic stem cell, mesenchymal stem cell. This is can be used for blood cancer transplant, blood cancer therapy. And then allogenic autologous stem cell transplantation, human stem cell therapy, allogenic and autologous. Indication, this is relapse after human cell therapy, and then lower relapse, and then this is for autologous initial response sensitive relapse. This is leukemia for many types for leukemia, CML, AML, ALL, and then blood cancer can be therapied using stem cell, and then stem cell can be use strategies to increase potentiating mesenchymal stem cell for therapy. This is mesenchymal therapy have many properties. Viral vector delivery, stem cell can be as drug delivery, and then prodrug activator, and then secrete interleukin, secrete TNF alpha, and then secrete trail, and then MMP2 growth factor, and anti-angiogenic agents. Anti-cancer gene therapy strategies using mesenchymal stem cell. Therapeutic gene use viral vector, non-viral vector, physical methods. This is ex vivo gene therapy using plasmid, and then transfection in mesenchymal stem cell, and then after infected using viral, the mesenchymal stem cell can be transplanted to the patient. And then many kinds of gene therapy, and then silencing gene therapy, suicide gene therapy, immunogene therapy. Stem cell therapy especially for cancer, mesenchymal stem cell, the properties mesenchymal stem cell have ability to migrate toward irradiated tumor, mesenchymal stem cell chemotaxis mediating factor, genetically engineer mesenchymal stem cell with anti-cancer activity to increase the properties of anti-cancer activity of stem cell. Mesenchymal stem cell primed with anti-cancer drugs, mesenchymal stem cell derive microvesicle. Properties of mesenchymal stem cell, homing many proteins which have ability to home. Mesenchymal stem cell have ability to home in cancer cell. And then mesenchymal stem cell secretes many kinds of growth factor which can inhibit but sometimes can progress to tumor or cancer cell. And stemness, many kind properties of stem cell. And then stem cell secrete interleukin, interferon, pro-apoptotic protein, and antagonist growth factor. Autologous allogenic stem cell transplantation for AML and ALL. This is times by times increasing therapy using stem cell. Anti-cancer potential of natural product, the resistant and side effect highly cause anti-cancer drugs. So many researchers find out the natural products which contain bioactive components having multiple targets and minimal side effect. From many plants like papaver, roses, anti-proliferative activity, and then Malvae pseudo Valvateria selective effect, AML, Urtica membranacea anti-cancer effect, and then many compound in plants, vincristine, irinotecan, and antinomycin, doxorubicin. This is from plant and can be used for anti-cancer. And then this is a chalcone flavonoid precursor. This is my research with my friends. This is 7 compound flavonoids have ability to decrease to inhibit cancer proliferation, blood cancer proliferation. This is our data, growth inhibition, and then cytotoxic activity leukemia on SK562 and HL60 lymphocyte selectivity index. If we have the data more than 2, selectivity index is a good substance which selective to normal cell and only attack to cancer cell. This is IC50 from 7 compounds and imatinib and acutan. This is substance number 4, a good anti-cancer. This is low IC50 and selective have a high selectivity index. And then morphological from 7 compounds. And then this is IC50 selective selectivity index from mangosteen peel extract, mangosteen peel extracts and alpha mangosteen, and then more active compared to imatinib and isotretinoin. This is mangosteen peel extract is a promising substance for blood cancer. And then caspase 3 FLT 3 apoptotic index compounds 6 and 7 selected from 7 compound. My friend and I do on compound 6 and compound 7 on HL6 T cell. We know that level of caspase 3 higher than control. Untreated cell, this is untreated cell, and then 2 FLT3 level of FLT3 lower than control, and then apoptosis compound 6 and 7 can increase the apoptotic index compared to control. And then cyclin day1 start 3 cell cycle compound 4 and compound 6 on blood cancer. We know that cyclin D1 lower compared to control, and then start 3 this is the best treatment, can lower start 3, and then our research compound 4, compound 6 potential for treating leukemia, inhibition cell proliferation by decreasing FLT3, inhibition P1 3K AKT signaling pathway, and then induction apoptosis by increasing caspase 3, blockade cell cycle progression by regulating cell cycle, increasing GTM and decreasing S phase. And then this is many plant can be used for blood cancer therapy, and then this is Urtica dioica extracts for AML cell line. This is lower proliferation and improve the cell cycle. This is plant-based derived reduce cancer cell migration. Many compound can be used inhibit cancer cell. This is the new therapy. This is still research, the engineered nanoparticle for drug delivery in cancer stem cell. I think that is, I introduce my book, Mesenchymal Stem Cell, dasar teori dan strategi aplikasi klinis untuk terapi kanker, and still in publisher, sel punca kanker, a target baru terapi kanker in bahasa Indonesia. I think that is maybe all participant can buy Mesenchymal Stem Cell e-books, and then sel punca kanker target baru in hard copy. Thank you very much, Dr. Hana.
Thank you to Ibu Dr. Wahyu for the presentation, for the information about stem cell and also about plant derived for blood cancer therapy. Now it's time for the discussion, but we only have 5 minutes for discussion. Please, anyone want to ask to Ibu Wahyu, you can write down in the chat box.
Okay, in the chat box. I think stop.
Dr. Jeff, is there a question? Okay, question number 1 from Dr. Herdi from Bandung. What is the general mechanism of action of herbs in killing cancer cells, especially in cases of leukemia? As we know that a lot of herbs are using to treat other diseases, so we have to be careful of the using of herbs. Please, Ibu Wahyu. And
Okay.
the next question, maybe it's also the same question. Can herbs be safely used in conjunction with other cancer therapy? Please, Ibu Wahyu.
Okay, thank you very much, Dr. Hana. This is using herbs of medical plants for blood cancer. As my research, that's with my friends, I do together with collaborate with my friends. That's how to inhibit cell proliferation. This is most of compound in plant, especially flavonoids, phenolic compounds, can inhibit cancer cell in many kinds of cancer cell, include blood cancer. Really, my research not only in blood cancer, little blood cancer research, and my focus in breast cancer. Flavonoids from plants can inhibit and to induce apoptosis. This is so the mechanism apoptosis, how to induce, and then and differentiated from cancer cell to normal cell, and then beside apoptosis, and then reactive oxygen species. I still do my research plant extract for cancer cell, especially breast cancer, to use reactive oxygen species. Reactive oxygen species can kill, inhibit proliferation of cell cancer. This is apoptosis, inducing apoptosis, and then differentiation, and then reactive oxygen species, and then senescence. How to make cell cancer become senescent. This is also the mechanism. And then the second question, what's Dr. Hana? Please
Can herbs
repeat.
be safely used in conjunction with other cancer therapy?
For other cancer therapy,
Uh,
I think that is
with
similar.
with not for, but with other cancer therapies. So for combination, herbs
Oh,
and cancer therapy.
Oh, drugs. I think that is herbal medicine. It is supporting therapy, not only use once or herbal therapy. This is only supporting therapy. So the standard therapy, still using standard therapy, and then herbal medicine only as a support therapy.
Okay.
And then
Only
maybe
for the support therapy.
yes, support therapy.
And for Dr. Heidi, maybe the research from Ibu Wahyu now is still in vitro research. I
Yes,
think.
still in
It's
vitro
still
research.
research. So
In Indonesia,
we
very
don't know.
difficult to make in vivo. In vivo, I don't have do in vivo.
Yeah,
Maybe
because
next, very difficult to mimic many kinds of cancer.
yes, jadi yes, I think it's still basic research in vitro research. From Mr. Phillips, uh, immortality. What can we do to deal with cancer cell telomere? This is
And
questions from Mr. Phillips.
oh, deal with cancer cell
Cell
telomere.
telomere.
I think that is cancer have immortality and then have long telomere. How to shorten the telomere? This is I do apologize because I don't research about the telomere. My research still focus in apoptosis and then differentiation and then cynation. And then right now I still do my research sorting of cancer cell become breast cancer stem cell as targeted therapy, and then brain cancer stem cell. Because cancer stem cell, if not die, cancer can be relapse. This is the source of proliferation cancer by cancer stem cells. So my research focus in how to kill and how to inhibit the cancer stem cell, not cancer, but cancer stem cell targeted
Okay, thank you
therapy.
for the answers. Yes, for Mr. Phillips, there's the answer from Ibu Wahyu.
Yes, I am sorry. I don't have experience about a telomere for cancer
Yes.
therapy.
Wahyu. Maybe this is the last question. In your research, Ibu Wahyu,
Yes,
uses the plants.
yes.
You use imatinib as comparison. Imatinib is a
Yes.
targeted therapy. Why you use imatinib for comparison? Because imatinib has a different mechanism.
Okay, thank you very much. I think that is imatinib usually as for therapy, and then for blood cancer therapy, and then the comparisons as comparison drugs, and use isotretinoin for drugs cancer therapy also. But I cannot find what's the comparison for
Because
apoptosis and then differentiation, and then many kinds of mechanism of my compound. from plants. So I use imatinib and isotretinoin.
Okay. Time flies, so we should end our webinar today. I think we have finished our webinar. Thank you to Ibu Wahyu for the presentation. And I would like to thank you to the committee and all the participants, and see you in the next webinar. Please, Dr. Hedi, maybe there's an announcement from you. Thank you.
Thank you very much, Dr. Hana. Thank you very much, Ibu Wahyu, for your sharing knowledge. Don't forget to all the participants that the certificate will be given to all of you who have attended this online seminar. And don't forget to fill this attendance and feedback link, which I have sent to the chat box. So this is the end of today's webinar series, Blood Cancers, Research, Diagnosis, and Treatment. Thank you for the presence of our guest speaker, Dr. Ting from Icon Center, Singapore. To Ibu Wahyu Widowati, thank you very much, Ibu Wahyu. And I congratulate you, happy birthday for 2 days. And maybe we can collaborate for our next international webinar, Ibu Wahyu. Thank you so much. And to our beloved moderator, Dr. Hana Ratnawati, thank you so much for moderating all this session. Thank you so much. Thanks for you all who have provided extraordinary knowledge, which has certainly enlightened us all. And lastly, I'm Dr. Hedi Herdiman. On behalf of the committee in charge, I'm apologizing profusely if there is a lackness in the implementation of this seminar. So thank you so much for all of you. Don't forget to fill the attendance and feedback link. So this is the end of the session. Thank you so much, and see you again on our next webinar. Thank you so much.
Thank you, Dr. Hedi. Thank you, Dr. Hana. Thank you,
Dr. Hana, Ibu Wahyu,
thank you, Dr. Diana.
Thank you so much.
Thank you so much for all participants.
Yeah, thank you.
Thank you. Bye.
Thank you. Bye.
To all the students, please still stay in this meeting because we have another session with Dr. Hana. Thank you. With Dr. Diana, I'm sorry, Dr. Hana, Dr. Diana. sorry.
Sorry. Sampai kaget saya.
Ya, mahasiswa, tolong tetap berada di sini. Kita langsung akan masuk ke acara penghargaan presentasi akademik mahasiswa FKUKM. Silakan yang mendapat penghargaan, ada 294 orang yang masuk Zoom. Yang lainnya boleh bergabung di YouTube. Yang kemarin sudah dipersiapkan foto-fotonya, silakan semuanya masuk Zoom. Yang lainnya boleh ke YouTube ya. Oke. kita mulai 10:05 ya.
Dokter Diana,
Ya, Dok.
ini tuh saya takutnya masih banyak partisipan yang dari yang tadi.
Ya.
Jadi kalau di end meeting dulu kemudian join lagi bagaimana? Jadi yang join lagi hanya mahasiswa.
Oh, boleh juga ya. Ide bagus.
Ya, begitu aja. Soalnya
Ya, Dok.
yang
Ya, Dok.
yang orang lain masih pada join. Jadi nanti sama Denny yang admitnya tolong di admitnya hanya mahasiswa saja. Takutnya ada yang join tadi tapi belum left meeting, Dok.
Oh iya, iya. Berarti di end dulu ya, Den? Di end dulu, nanti masuk lagi. Ya.
Tolong diumumkan saja ke mahasiswanya, mungkin angkatannya ya, Yosua dan lain-lain ya. Jadi kita akan end meeting dulu, nanti silakan join lagi agar yang join lagi meeting selanjutnya hanya murni mahasiswa. Atau enggak mau pakai link yang baru, terserah Denny saja sama Dr. Diana, biar tidak terganggu oleh partisipan yang acara pagi gitu.
Mau link baru, Den? Link baru aja tuh. Nge-share-nya di grup mahasiswa.